Welcome to the OrthoEd segment. Today, we're lucky enough to be joined with Dr. Jeff Hall, of course, the founder of OrthoEd. We're going to be going through a few steps with the next couple of episodes where we're going to do the diagnosis of my ClinCheck. We're going to talk about the risks that you should be thinking about, just broadly, and then talking about the changes that Jeff would actually make to my ClinCheck as the first steps. So welcome to the segment, Jeff.
David, great to be speaking to you.
So, and if anyone's interested in Jeff, we've done a podcast, a full episode. It's only a couple of months ago, late 2020, so check it out. So Jeff, this is me, as you know. I want to just go through a little bit of diagnosis, and I'd love to hear, what is your thought process as you go through the diagnosis?
Okay, so if we just get a look at the intraoral photos to start off with. So I'm looking at your intraoral photos, and you've got a very interesting and challenging case.
Good.
You have so I'm looking at the buccal segments, I'm looking at the molar relationship and the canine. You've got a beautiful, soft-in class 1 molar, premolar, and canine. Mm-hmm. So the last thing we want to do, either on your right side or your left side, because you've got a really nice class 1 soft-in occlusion on both sides, is to change your buccal relationship significantly. So if it's not broken, you don't want to fix it. So I'm looking at that. Now, usually teeth fit together like a jigsaw puzzle. So if I'm seeing a perfect class 1, I would normally like to see a perfect overbite overcheck. Now, I'm not seeing that with you. So I'm thinking to myself, something's got to give. So I'm looking now at the center line. That you've got a deviated center line, and I'm assuming we would have to look at your facial photographs to assess the center line. We've got to figure out the boundaries. What is our boundary with the tooth movement? So I'm assuming your upper center line is correct. I mean, we can look at your extraoral photographs, but I'm assuming that, and if that's the case, your lower center line is now shifted significantly to your left-hand side. So you've got a minimal overbite and you've got a crossbite on the 2-2, but your 3-2 is significantly labally positioned. And when we look at your intraoral photos, you've got significant recession of that 3-2. So we've got to ask ourselves the question, realistically, can we move that 3-2 back or not? Because if you're going to move the anterior teeth forwards, which is the predominant way of resolving crowding, even if we round trip the case, you're going to end up with further recession on that 3-2. And you've got a fairly thin gingival tissue on the 4-1, 4-2 as well. So if I can move the photographs down, because I want to have a look at so you've got, and now, as I said before, I'm looking at you've got a beautiful class 1 occlusion posteriorly, and I'm saying to myself, why isn't the anterior segment right? What's wrong with that? And when I look at that, I've got to say to myself, the first thing I'm going to be thinking of, have you got a Bolton discrepancy? And I think that's probably the most missed part of orthodontics. It's been around since the early 50s, the Bolton analysis. And with Invisalign, you can actually have a look at your Bolton analysis, and it says here you've got a mandibular excess of 1.69 millimeters. Now, when I look at that clinically, as a clinical guide, your lower lateral incisors should be about the same width as your upper laterals. So if I just look at that, so just as a clinical, if you were looking at a patient in the mouth and you didn't have models and measurements, you would look at the width of your mandibular laterals, and they should be about the same width as your upper laterals. And if they're not, you've probably got a Bolton discrepancy. So when you've got a Bolton discrepancy, you're either going to do a lot of IPR, which is exactly what they've done here on your ClinCheck, okay? Or do you consider taking out a lower incisor tooth? And this is, now, when I look at the lower left lateral here, the root is so far lingually positioned, that's what's going to take you a lot of time to move. So we would have to ask ourselves, we need to get all this space if we're going to do this non-extraction. And if we're going to do that, we're going to expand the arches, which I think we need a bit of posterior expansion.
Mm-hmm.
but we've got to be really careful not to expand in this segment here with the 3-2. So, and you've also got your 2-2, which is in crossbite, probably related to your peg-shaped lateral incisors.
Mm-hmm.
So in the ideal world, if we could build those up a little bit as well, but when I'm looking at your case, I'm thinking to myself, I think we take out that lower left lateral incisor. And that's going to bring some other risks that we've got to address in your ClinCheck setup as well. But I think to mitigate the possibility of further recession, I think we'd probably be looking at taking that 3-2 out. Because when you look at that, if you just imagine by the time I bring that central in place, I've taken the 3-2 out, you've probably only got two, maybe maximum 3 millimeters of spacing left over. And we can resolve that very adequately with a line of therapy.
So that's really interesting. That's exactly what I've been thinking about my mouth, and when I'm thinking about this case. 2 quick questions. They're a little bit different. One, I've got a Bolton discrepancy of 1.69, and then they've done IPR of about 1.5. If you're trying to help, with get your Bolton discrepancy back down, is your IPR usually going to be exactly the same?
No, because you need your IPR, one for your Bolton discrepancy, agreed, but 2 to also alleviate your crowding. So to me, what they would have done, I'm sure if we go in here.
Yes, I understand.
If we go in here, we do if we do a superimposition and we go all the way across, so they would have also expanded
I understand,
and advanced to lower anteriors as well.
Yeah, so it's tooth shape, not crowding that would address. Yeah.
So you should, in all honesty, there should be far more IPR being done here to minimise the advancement of those anterior teeth. Hence the reason why I'm thinking of another reason why I'm thinking of lower incisor extraction.
Makes perfect sense. And that's something we'll talk about in the next segment about risks. So let's just ask one more question. Talking about records that we need, obviously we need impressions, scans, we need photos. Do we always need a LAT-CEF?
That's a really good question. What I teach in the course, I think a LAT-CEF is really overutilised. Too many people diagnose from the lateral CEF, and they make a diagnosis, and I want to diagnose from the face. But what I talk about is the lateral CEF is supposed to confirm your clinical diagnosis. So no different to, in all honesty, to when we do endo, we have a clinical diagnosis and the radiograph should confirm it. It's very rare that we should totally diagnose from a radiograph, that we confirm it with the radiograph. So to cut a long story short, yes, you do need a lateral CEF. I'm going to say that from a medico-legal point of view.
Yeah, that's fair.
My orthodontic colleagues, because it's so ingrained in them and the way they've been taught, which it doesn't mean it's right, but that's the way they've been taught, you would be negligent if you didn't have one.
Yeah.
But personally, I don't think you need one.
Yeah, that really does sum it up, though. We need to have a clinical diagnosis. X-rays support that diagnosis, but it's important record keeping. That does sum it up. So I've got a class 1 molar, class 1 canine, but I don't have a lot of space and some significant risks. So in the next OrthoEd segment, we're going to talk about those risks, and we'll get to what you'll actually do with changing this ClinCheck step 1 in the episode after that. So thank you, Jeff, for sharing that with us.
David, thank you very much.